we'll request Sir to give his keynote address on what is the present situation of health in India, and of course, if possible, on Telangana also. But later we will be having a much more critical discussion. I'll first request Srinath Reddy garu to come on the dais.
Sir.
గుడ్ మార్నింగ్. తెలంగాణ మిత్రులకు తెలుగులోనే నేను నమస్కారం చెప్తాను. బట్ బేసికలీ ఐ బీన్ ఆస్క్డ్ టు స్పీక్ ఇన్ ఇంగ్లీష్ బికాస్ the audience is from all over the country. Initially, when Indranil asked me to attend the meeting, of course, I was very happy that it was on a Sunday where I could come in despite other committed meetings elsewhere, which occupied me yesterday and will occupy me tomorrow. But he said, you have to speak about the health conditions of Telangana. I said, there are people from Telangana who know much more about it than I do. I'd rather come and learn from them rather than trying to gather some information and then pretend to be a very knowledgeable expert on what exactly is happening on the ground. But he suggested that we can discuss overall challenges of health in the country and then focus particularly on Telangana afterwards. I'll try to do that. Let me first talk about the transition in the semantics and where actually reality is lying with respect to universal health coverage. When the HLEJ report on universal health coverage came out in 2011, there were a lot of controversies. One was on the nomenclature itself, whether universal health coverage is the right word or the universal health care is the right word. There is absolutely no question that care is the most important element, and if coverage is interpreted purely as a notional insurance coverage, then that's absolutely incorrect, incomplete. However, because the 2005 World Health Assembly resolution, as well as the 2010 report of the WHO on health financing, all of these had adopted the term universal health coverage. It was decided that we'll continue to use that term, which even the government of India of the day had accepted, but interpret it in our own way, which essentially meant that all services from health promotion to disease prevention, timely diagnostic assessment, cost-effective clinical care, and rehabilitation and palliation would be offered at all levels of healthcare in an integrated fashion and without any financial hardship to the people, with public financing as the main source of financing, supplemented by social health insurance, and maybe if people want to purchase private insurance, that may be there, but essentially we said it should be public financed. Now, the question of whether the particular proposal of universal health coverage, which was hinted at in the 12th five-year plan but never implemented then, has advanced through Ayushman Bharat is a question. There are 4 components of Ayushman Bharat: primary health care through the health and wellness centers and the rest of the connected primary health care system. Then the Pradhan Mantri Jan Arogya Yojana for secondary and tertiary care, hospitalized coverage through accredited facilities. Then the digital health mission, which is supposed to provide the connectivity at all levels, and the health infrastructure mission, which is supposed to further strengthen the government capacity for delivering healthcare through healthcare facilities, and also build surveillance systems alongside for infectious diseases, which became particularly a major priority at the time of post-COVID. In a sense, theoretically, these four components can provide a matrix for universal health coverage, provided each one of them is functioning efficiently and all of them are connected as well in a seamless manner in an integrated healthcare system. But it still leaves out the very many determinants of health which lie outside the healthcare system. So when we want health beyond healthcare, we have to talk about the social, economic, environmental, commercial determinants of health. And without that, we will not be able to create a healthy society. And even access to healthcare would be greatly impeded or, in a sense, distorted if we do not address the social and other determinants of health. So this particular unifying concept has to be really projected whenever we discuss about universal health coverage. The way I have tried to project it in some of my talks and even in some of my publications is in the form of three concentric circles. The innermost circle would be health financing, which has to be predominantly tax funded, public financing, supplemented if needed and wherever possible by social health insurance and other forms of insurance. But it has to be predominantly public finance because no country has achieved universal health coverage without adequate public financing. The second circle would be well-functioning and well-integrated elements of the health system, which means a multi-layered, multi-skilled health workforce. It means assured supply of drugs, vaccines, equipment, and whatever current technologies are also emerging for healthcare. Third, assurance that we have health information systems which are providing timely, representative, and accurate information for guiding health policies, assessing health programs, and modifying them as per need. Community engagement, all of these become very important elements of a well-functioning healthcare system. Then, of course, we have a third circle. If we add these two circles, yes, we may be saying that we are providing universal health coverage, but we will not provide the foundations of a healthy society or even achieve universal health coverage in the right manner if we do not cover the various determinants of health, which operate at the broader societal level and also at the individual level. Water, sanitation, all of this, air quality, all of these become very important environmental determinants, but also the ability of communities to live in peace without conflict, without discrimination, all of this becomes important as an important determinant of health. Then you also have the determinants which are actually socially determined but represented much more at the individual level in terms of education, income, employment, gender, participation in social networks, etc. So unless the third circle is also attended to, we cannot have assurance of a healthy society, and we cannot even assume that universal health coverage, even in the limited sense of the word, of health services are going to be delivered with efficiency and equity. So if we really want to create a society or a system in which all the health services are available, effectively delivered in an empathetic manner, with economically viable system, providing the services without imposing an economic burden on the people who are accessing the services, then we have to attend to all of these in a fairly integrated manner. So in the preface to the HLEJ report, I had used a term saying that what we need is not health insurance, what we need is health assurance. I was a little surprised later on when it was picked up by the current government, and they now are using the term health assurance quite freely, which is fine, as long as they define what it means. Because our definition of health insurance was that all of these elements will have to be integrated. Now, what we need to do is to ensure that each one of them is not only assessed independently for how well it is being delivered, but how well the entire system is functioning well in an integrated manner. We have tremendous amount of disconnects in the health system. We have disconnects between primary care, secondary care, and tertiary care. The bidirectional flow and continuity of care is not being assured. Care being rendered in primary care close to home or at home to some extent through the Ayushman Arogya Mandirs or whatever they are being called is possible, but we need to ensure that it's actually happening through people being positioned there as human resources and equipment and supplies being assured and distances being bridged. All of these become very important, and we know that in the number of underserved areas across the country where even that modicum of primary care doesn't exist well. Urban primary care particularly has been a casualty because of the facile assumption that urban areas anyway have enough doctors, there won't be need for much of primary care, except for a few places where good municipal health services do exist. By and large, urban primary health care has been left to either the care of private practitioners or corporate hospitals to people will have to run to even for primary care. So there are a number of lacunae even in primary care which need to be attended to. Secondary care is a major challenge, and there, unless we greatly strengthen our public health care infrastructure at the district and sub-district level, we are going to see a lot of gaps there. Tertiary care has been practically handed over to the private sector, and we have, despite all the promises of the various aims, etc., coming up, we find them understaffed, not really being able to serve the purpose. And unless we strengthen our tertiary care also in a manner that the needs are served, we're going to have problems. But